Isn't Kindle's thing?
Oh, is she not here? Yeah, they left, so she asked if someone would record it. I don't get how that works. Well, she told me to just push the button. Oh. So, hopefully it's recording.
Abby was looking at hers and she had accepted the max for the other.
Did I miss anything in the Dragon Boat
But
file?
then I got the max from the Direct Plus too, which I'm gonna be returning because I don't need the 11,000. I just need the 7. And the interest on
Did I
that
miss
one.
anything in Dragon Boat?
No, we don't have class Tuesday, and there's gonna be like a video and an assignment to do, but it's not gonna be up until Tuesday, like on the day.
Oh, I see.
Like it won't be up beforehand.
I don't think we have law Tuesday.
That's what Brielle, you said we don't have law Tuesday?
No, we don't have any classes Tuesday.
Nice.
Is
Like
he
I knew
gonna
we
do
had
a
law today,
review?
but I didn't know about it. I guess he's doing it
How
today.
is he gonna finish the whole
I don't know.
PowerPoint?
I don't get it either.
And go over the test?
I practiced the dance today. I'm not very
No,
good,
you
but
remember you said I felt like no class.
it was so fast and I was getting dizzy.
Did Woody have fun? Was he
Yes.
okay with the other dog?
Yeah, he was.
So this
He
is
did
what
run
class
into like a
everybody
puddle
looking
though.
forward to all
And I was like,
semester.
what the fuck?
I'm surprised.
Last class of
I know,
all.
that's what I said.
But
He was
we're
he
gonna
was
finish
just,
the
like,
notes at the
puddling
same time.
by the
Work out well.
deck where you
We've got
go,
a
like, in the
standing
gravel
roll
area.
crowd in Athens
I was
today.
like,
We've got a
what
lot of
the
folks
fuck?
that have already traveled up,
Yeah,
getting
I
ready for the
love
pinning
that.
ceremony tomorrow
Did you
night.
just say
Look forward to
standing
seeing
room
all of you
crowd?
there. And your friends and family, people that
Wait,
are
what?
support you to be where you are right now in pharmacy school, see you go through that process.
We good number first?
Who's
The
standing?
rest of y'all be careful coming up and over. We'll look forward to seeing all of you there very soon.
And so you're just taking what you need.
Yeah, like I ended up doing.
As promised, one of the first things we're going to do today is go over just topic-wise some of the things that are on the final exam. I didn't want to pass up the opportunity to say a few things about the General Assembly. They finished up, they're kind of on the same schedule we're on. They finished up Tuesday night at midnight. They always have a ceremonial throwing of paper bills into the air when they finish up and leave a mess for the janitorial staff to pick up. Kind of interesting, and I will follow up with you with an email in the next few days thinking about law as far as the things we talked about. Most surprising thing to me, and I think I had told y'all somewhere in the semester that I didn't have a chance of passing this year, the medical marijuana. Update the medical marijuana law passed. In just the last 10 minutes of the session. I mean, it took all day. He kept sending things back and forth in the House and Senate.
Why is my
They did
PowerPoint
pass.
look like that? I don't know, I changed the background twice.
It's something that we really haven't spent a whole lot of time
Try to
talking
format
about.
background. Design format background.
They actually included a section in there that the Board of Pharmacy will be responsible for promulgating rules and regulations to allow medical marijuana to be dispensed in the pharmacies in the state of Georgia. Not necessarily every pharmacy, there may be an additional application, things like that, remains to be seen. But that will definitely be something that will be happening very possibly over the next couple of years, but during your practice lifetime,
Yeah.
or how that is handled. So it just goes to show you that, once again, things can change very drastically when the legislature is in session. We were talking here in Canada about, I said, yeah, in a couple of years, you may hear that all these laws now, that's all these new regulations, but we'll see how that goes. And like I said, I will send out some stuff on that, just to update you on that as we're going through the last of the semester. Also want to mention too, please keep your eyes open. I'll be sending you some update emails. You may be getting something from Dr. Fagan. We still have the IPE module to do, and she has arranged to do that on each individual campus with a mixture of medical students. Some campuses I think use Zoom 2, some are using Zoom 3s. It'll be interesting to see how all that ethics component works out on that. Before I get into the notes, make sure, I don't think we're going to run right up to the last minute today, but I want to make sure you have a chance to hear me go through the topic list for the final exam. And I've just looked at the questions and kind of written the general area of the notes these came from. So you kind of have an idea of how to target yourself, although realistically I think you'll see it pretty much is spread throughout the whole semester. It definitely starts out with a few questions on what I refer to as the laws that are the basis of pharmacy practice. History, basically, of those initial laws and acts that established the basis of pharmacy practice, all the way back to the Food, Drug, and Cosmetic Act and to
That'd be
the
all my undergrads.
Pure Food and Drug Act. Again, things like adulterated and misbranded products are in the news all the time. Just yesterday, I got something from ADP. The chairman of the FDA is retiring, and he is calling on that to be one of the things they tighten up on the FDA. The fact that basically talking about all these blood pressure medicines that have come out and have been taken off the market because of contamination, adulteration. So realize that some of those early terms are still important in the daily practice. Some information, a couple of questions on FDA requirements for labeling. Remember we talked about the specific label for like manufacturer's container, but also the other components of that, including the package insert. Prescribers in Georgia. Definitely several questions on that. Remember to be able to distinguish between licensed prescribers, those that by virtue of their license have prescriptive authority, versus those that don't, mid-level prescribers, and the specifics as far as optometrists and things like that. Requirements for controlled substance prescriptions. That's a simple few words. It can cover a lot of different things, but definitely the specific requirements for C2 prescriptions versus 3, 4s, and 5s. Things like we reviewed yesterday or on Tuesday, as far as special cases for C2 prescriptions, emergency prescriptions, also when a fax can be used as the original for those 3 purposes. Other specifics as far as expiration dates, sequential, writing sequential C2s for future filling, things like that. Definitely the Georgia specific categories of controlled substances and dangerous drugs. For dangerous drugs, for all those prescription drugs that aren't controlled substances in the state of Georgia. DEA registration requirements, who has to have that. How good the DEA, how long the DEA registration is good for. Again, remember that it calls off cycles to your pharmacist and pharmacy licenses. The specifics about control 5, C5s in Georgia. We've got 2 different distinct categories. We've got pseudoephedrine C5s, we've got non-pseudoephedrine C5s. And how those are handled, specific requirements of those. The DEA forms, again, there's thousands of those. I feel like we need to know about those 3. Definitely about controlled substance ordering, the CSAUS, as well as Form 222. Disposal of prescription drugs. And I actually had a long chain of texts last night with one of your faculty members about disposing of drugs at a clinic there in Athens that is run by charity and doesn't have the money to do reverse distributors, and got into an interesting discussion about how they could get rid of expired drugs. So that's definitely a case. And remember, we've talked about 2 already. We'll talk about a 3rd one today. Categories of those: retail pharmacy, health system pharmacy, and today we'll talk about long-term care facility pharmacies. Because yet again, it has a little different set of requirements. Product substitution. Remember, that covers a lot of different things: generic drugs, bioequivalent drugs, biosimilar drugs, and the specifics on that. Definitely know about those AB ratings. Prescription copies, transfers, who can do it, what rules apply, dangerous drugs versus controlled substances, people sharing common database, all those types of things. Having trouble reading my notes? Oh, okay. Ownership of a prescription. That one's pretty specific. Who actually owns the prescription before it's filled? When there are cases when you can retain the prescription, you should return it to the patient. Controlled substance regulations, specifically inventory. Specifically, when do you have to have a perpetual inventory? When do you have to do, or what are the requirements of the biennial controlled substance inventory? Pharmacists and pharmacy licensure. We talked about a lot of different types of licensures or permits. Some of them are called pharmacy permits, pharmacist or pharmacy licenses. CE requirements for pharmacy licenses. Pharmacist. Pharmacy department security. And requirements as far as a pharmacist being absent from a pharmacy. Specific number of hours, times a day, things like that. What has to happen when the pharmacist is not available in the prescription department. When it's closed. Drive-through windows. Okay, a few questions on different types of pharmacy practice, specifically hospital pharmacy. I know they call them health systems now, but laws call them hospital pharmacies. They also call community pharmacies retail pharmacies. And let's see, I think we'll talk today about outpatient clinic pharmacies. And we'll talk about some specifics for that. Again, it's kind of like the term dangerous drugs. There's, I call them capital letters, outpatient clinic pharmacy, and then there's pharmacies that just have to be filling for outpatient. Okay, but there is a specific licensure category for outpatient clinic pharmacy, and it has some very specific restrictions. The categories, low, medium, and high risk for home use sterile drugs, sterile compounding. In the various types of permits that we talked about, DEA numbers for people working under a hospital registration. Getting drugs to market. A couple of questions on that. And we talked about phase 1, 2, and 3 trials, INDs, NDAs. Another one on drug product substitution. And that's it. 50 questions. It's designed to be an hour exam. It'll be timed for 75 minutes. Most of you haven't taken the whole time before, but it won't be like a double length exam. It's going to be during our regular class period next Thursday. Remember, today's the last class period, so we don't have class on Tuesday. I heard today you don't have drug information on Tuesday. So y'all have all day next Tuesday to study law. Right? Thank you, Dr. Met. Okay. So picking up with the part 4 of the Georgia State Board of Pharmacy Rules and Regs. Again, I'm using for this the outline then on the web as far as the Georgia Board regulations. We're going to finish up through these today. There are several sections at the end that just have to do with administrative operation of the Board of Pharmacy. We don't cover them. As far as what's required to get quorum and how often they have to announce when they have a board meeting, all that stuff. So we're going to go through the RAM system today, and we've covered another couple that are beyond that. First up, though, is long-term care regulations. Whether you call those nursing homes, long-term care facilities, whatever, and they also include hospice emergency drug kits. They don't really talk about hospice operation in general, but these hospice emergency drug kits are yet again one of those kit-type situations, similar to what our EMS might have, what you might have on a crash cart, or what those home healthcare nurses might have. We'll talk about that as what the requirements are. Big difference with long-term care is it varies, or it gets away from the traditional PIC component. There's basically 2 kinds of pharmacists that are involved in long-term care. There's the consultant pharmacist, and then there's the vendor pharmacist. Now, they can be the same person, but frequently it's 2 different people at least, and often it's 2 totally different companies. The vendor pharmacist is the one that has the contract to supply the actual medications to the long-term care facility. There are requirements for long-term care facilities that they have a pharmacist review the regimen of every single patient at least once every month. So it's a pretty big career opportunity out there that may not be involved at all in dispensing a product, but just in doing review of patient charts. Again, making sure that if there's polypharmacy going on, that somebody in a nursing home is not just put on a drug and left on it for the rest of their life, things like that. So again, at a minimum, and it's pretty much stated as this is what's done, but realize it does say at a minimum, they must review each regimen monthly and report to the medical director, which is usually the physician, and the administrator of the long-term care facility. If patients aren't being followed by their healthcare providers, and there are medications, and there's a list of medications, I know y'all talk about the VEERS report, VEERS list of drugs, and things like that for elderly patients. If there are providers who aren't paying attention to that, the consultant pharmacist is the one that calls them about that and actually follows up with the medical director and the administrator of the long-term care facility to make sure they're doing the right thing. Vendor pharmacy is more like the types of pharmacists we've been talking to. They're the ones that provide the medications. They're the ones responsible for labeling, getting them in there where they can be administered to patients, things like that. Like I said, it can be the same, don't have to be. No specific space requirements, since these are more dispensing type entities anyway. Definitely talk about things that they must have appropriate storage, cleanly area, things like this as far as handling the pharmacy. Okay, destruction of pharmaceuticals in long-term care facilities. Is it like a community hospital? No. Is it like a hospital? No. It's got to be something different. So there's really three basic categories. Know this for the log thing, know this for the MPJE, and then specifically when you start practicing in one or more of these areas, you want to know how it's handled in those different areas. It is different for long-term care facilities. They do differentiate between on-site and off-site. Because again, just like in a health system or a hospital, there is the need sometimes to do destruction on-site when a partial dosage unit is used or something like that. But then the off-site means you can return it to the vendor pharmacy, and that gets a little easier. That's more like a traditional community practice. On-site, the big difference is that it's required that drugs that are destroyed on-site be witnessed, signed for by the consultant pharmacist and at least 2 other people. Okay, again, realize that might be the only pharmacist on-site, so it doesn't have to be 2 pharmacists. It could be a pharmacist, a nurse, law enforcement, or it can be sent back to a reverse distributor. They must notify the GDNA as part of their licensure, or as how they're going to do that. And they have to notify the GDNA and show them the record of destruction that was done on site. Big difference here is it's 3 total people, not just 2, like all the other ones. Off-site is when it's returned to the vendor pharmacy. They can use a reverse distributor or GDNA witness. The reverse distributor is the same thing that can happen in a community pharmacy. GDNA has to witness, remember in community pharmacy, they have to witness controlled substance destruction, but they will not get involved in destruction of non-controlled substances. This was the discussion I got into last night with one of their other faculty members. There's actually no mechanism for destruction of non-controlled substances, dangerous drugs, on site in a pharmacy. The only thing the regulations list is that those can be returned to a reverse distributor. Usually some money involved in that. This clinic doesn't have funds to do that, and they were wanting to take their drugs to a local law enforcement site where they had one of those drug disposal or drug return, turn back receptacles. And I said that's a really good idea, but there's nothing in the pharmacy regulations to say pharmacists can do that. Or the part we got really concerned about was they were going to have a pharmacy student do that. And again, know what you did. We said that you may have to break some laws. Good practice of pharmacy in the state of Georgia. You want to know what laws you're breaking. You want to know why you're doing it. If you're doing it for your own advantage, the GDNA is going to have a problem with that. So it's definitely better than just throwing them away in the trash here at the clinic, probably. But they wanted me to be able to tell them what they could do so they wouldn't have to worry about it. And I'm afraid I'm not going to be able to give you that answer because there's nothing like that available. Okay, so the main thing with long-term care facilities is to know about the 2 different types of pharmacists, consultant pharmacists and vendor pharmacists, and the difference in how they dispose of drugs, specifically the on-site. Okay, also added in that, just because hospice, the closest thing to that with long-term care facilities, they put in their hospice emergency drug kits. This is very similar to the kits that are used by EMS or EMTs. There's the requirement of a 30-day inspection by the pharmacy, 72 hours to document any drug use. Here's the big difference in that. These are drugs, this is not listed in the rules and regs. This is from another website that lists some things that might be included in a hospice drug kit. Notice that several of these are controlled substances, including morphine liquid. Very high potential for use, very highly controlled, C2 drug. Again, this is specific only to hospice practice, and again, that's part of what they do in hospice, end-of-life care, supportive care. Frequently, they do have things including controlled substances, maybe some benzodiazepines, but definitely morphine, usually in a liquid form, to help ease the pain as a patient is experiencing end of life. So very specific requirements there. You definitely have to follow up on that as far as the pharmacy that provides this. Again, it could be provided by a more traditional retail pharmacy, or it could be provided by a health system pharmacy. Okay? The next section has to do with some exceptions to the regular prescribing requirements. The main thing having to do with the patient name for a prescription. These drugs specifically, by Georgia regulation, do not require a specific patient name. And more so that they can be prescribed to an entity or a facility or to an ambulance service, Little League ballpark, things like this, can actually have these medications on hand and can have prescriptions issued to them. We've also talked about how naloxone is available now to a standing order in the state of Georgia. Basically, anybody can walk into any pharmacy and request to get a prescription for naloxone, injectable or the nasal dosage form. And there is a standing order you can print off from the Department of Community Health, link to the pharmacy website that's technically not under the Board of Pharmacists, it's the Department of Community Health, to have that printout and put the person's or the entity's name on it, and that can be used as a prescription to issue them naloxone. Similarly, again, it does require a prescription, but a prescription can be written for an EpiPen, for a restaurant, a ballpark, an entity. It doesn't have to be a specific person. That's where it's different than traditional drugs. And also, lesser known, albuterol and other types of inhalers, rescue inhalers for asthma. Specifically, those are usually used by local school boards or local schools. They have where the school nurse will have those. Again, it's the kind of thing when a student, patient needs that, they don't need to be waiting around until they get one brought home or whatever. So those can be licensed or prescribed for an entity to have on board. E-prescribing considerations, we've talked about that. I tried to not separate out e-prescribing from the regular prescription requirements, but we are going to hit them one last time. Realize these are much more recent rules than the ones for handwritten prescriptions. But I know in Georgia particularly, we are now getting more and more of our prescriptions by e-prescribing. Several states, I think the second or third state now, has passed legislation to require all prescriptions to be e-prescribed, except for certain circumstances. Will Georgia get to that? Possibly. I think it'll still be a while. But do realize, especially now that controlled substances are available by e-prescribing all the way up to C2s, we are going to see an increase in e-prescribing considerations. In Georgia, when we talk about electronic prescriptions, they basically divide them into three categories. They still refer to fax prescriptions as electronic because it comes through that device, by your phone. But it does have some specific requirements. Electronic transmission via computer to computer is the type that we see most frequently now, or the increase in. That is how we can get controlled substances all the way up to C2s prescribed. Through that, it does come through a documenting or a formatter, comes through SureScripts. And then the third is email, and basically just plan to avoid email prescriptions. In the state of Georgia, we'll talk about the specifics on it, but there's just really no way of documenting your security on email, as most of you know on that. And so it is not encouraged. It is listed in the regulations, and some physicians insist on doing it, but especially now that electronic prescribing is available, it really ought to go that way. Unique things to facsimile is that it must have no other intervening person or intermediary. Fax prescriptions, when you get those to your pharmacy, it has to come directly from that prescriber's office. Okay? That prescriber's office can't send it over to their affiliate prescriber and have them send it in. They can't, have a nurse practitioner here prescribing and sending it to the supervising prescribers. office and then having it sent to the pharmacy, it has to come direct. Okay? And definitely no patient can transmit a prescription drug to a pharmacy. Patients can definitely fax you their prescription. You have people who want to do that all the time. Save them a few minutes. You know, I'm going to go ahead and fax these to you, and I'll bring you the hard copies when I come. Just realize there's no legal standing for that fax prescription coming from the patient. You elect to go ahead and get it ready, and that's fine, but you know, don't be putting that prescription in the file and expecting the PDNA to take that as far as the original prescription. This is the way it's still worded in the Georgia law. Electronically transcribed prescriptions may not be for controlled substances, except as may be allowed by federal law. That's been in there for about 15 or 20 years. In that amount of time, of course, it is now allowed because it is allowed by federal law. It's been allowed since 2010. 3, 4s, and 5s came on a few years ago, and really only in the last year are most of y'all telling me they're getting C2 prescriptions electronically. Didn't make this in blue, but it's very important, and I wouldn't doubt you're going to see this on exams. If a physician's office, and basically all of them, prescriber's office, all of them have electronic medical records now, everything's done on computer. And they'll ask the patient, you know, which pharmacy they want to send it to, and supposedly they sent it to that pharmacy, and of course, as we all know, they end up sending it, whatever it was the last pharmacy they sent it to, so you have to chase it around. But if the patient insists and says, no, I really want to get a paper prescription, I want to do it for a mail order or whatever, they can't just print that out on plain bond paper. Okay? For the obvious reason that you can make an infinite number of copies of that if you print it out on plain paper. It must be printed on security paper and signed in the office. Just an electronic signature on that type of prescription is not okay because, again, it can be reproduced multiple times by the patient. They actually have the copy on a plain white piece of paper. Email prescriptions, here's what makes it so difficult. It must be encrypted, accompanied by a digital ID for authentication purposes. Nobody really knows what that is, so basically don't use this method. It needs to be secure if somebody's going to use email. They put this in there, again, well before electronic prescribing was even a thing. It was approved for controlled substances. So just avoid, you've got prescriber's office still trying to email you prescriptions. It's time to kind of cut that off. It's still defined in the regulations, but again, nobody really knows what this is unless you can confirm that it's encrypted and authenticated with a digital ID. You really shouldn't be accepting that as a legal prescription. NPI number we talked about a lot. Back in the day, we used to use DEA number all the time to identify the prescriber. As you know, because we just had the class, all the DEA number does is tell you if that person can write controlled substance. Okay? There's definitely plenty of prescribers who don't have DEA number. So the most appropriate thing now for identifying the prescriber is the NPI number. And again, most third parties now require you to have that on there. Again, because these laws are newer, it actually says in the regs for electronic prescriptions that the prescription must include the prescriber's NPI number. So for electronic prescriptions, no matter who's the prescriber, remember we also saw that in APRN regulations and in physician assistant regulations, again, because those are relatively new, they include the NPI number. DEA only requires specifically if that's for a controlled substance. But they would have to have both the NPI number and the DEA number. So we're working toward requiring that NPI number for everything. Technically in Georgia, for licensed prescribers, it is not a requirement for their prescriptions to have that on there unless it's electronic. But hopefully most of them are going ahead and doing that. And most of them use an electronic prescription. Transfer, remember for dangerous drugs, there's no limitation based on, as long as there's still refills, valid refills left on that. You do have to note it in the records of the pharmacy that's offering the transfer. The idea is you don't keep filling it in both places. Definitely more limits on controlled substances. And we talked about shared database, how they can fill it with a maximum number of refills, again, as long as it hasn't expired otherwise. And there is one-time transfer for controlled substances unless the two pharmacies that are transferring it to each other share a common database. Just one of them has a common database. So basically, within that same chain, will we ever get to the point where they can see each other's? I don't know, probably not. But one time only for controlled substance transfers, unless the pharmacies that are transferring it between each other share a common database. Again, with the main thing being there, you don't want to have that patient go back and get refills at both places.
I engraved mine.
What'd you get?
Here's my name.
Okay, there's a section called Other Considerations in the rules and regs. And this is for, again, some of those things that don't fit anywhere else. One of the first things under that has to do with forged prescription and how you can, what is legal to give to law enforcement as far as using this as evidence of a crime. Basically, if a prescription is forged and you have reason to think that it's forged and you call law enforcement, they're going to investigate the case. Again, the case hasn't been decided yet, so the jury could still be out. But if you have reason to believe it's a forged prescription to the point you call law enforcement, it is perfectly okay to give that original prescription to law enforcement, and they have to give you a signed photocopy saying who's got it, how you can reach it, so that it doesn't just disappear. It is true that they must have the original prescription as evidence, or else they have no case. In any case, it's been thrown out of court, somebody only has a copy of the prescription. So they do have to have the original prescription, and they tell you, no, I don't need the original prescription. The copy will be fine for now. That's okay, but realize they are going to need that original copy as evidence that this thing goes to court, and they try to convict someone according to that prescription. Also, under that other considerations, there's a section in the Georgia Board of Pharmacy regulations on practitioner dispensing. There's also some information in the medical board regulations on this. This was a hot topic back in the 80s, back when the third parties were just starting to be so prevalent and they were cutting down on reimbursement rates to prescribers. This was kind of billed by the companies that were providing these kits to prescribers. They could do their own dispensing. It was being billed to them or marketed to them by saying, this is the way of making back up that extra money you're losing on every patient you see. And you actually dispense their medications also. As many of you know through your work experience, most prescribers have a relatively limited formulary of certain drugs they use. So basically, this company would come in, talk to the prescribers, go through their records and find out what drugs they were using, and they would make 80 to 90% of these drugs available to them on a prepackaged basis in a little cabinet, and they could just go in there and pull these out, slap the patient name on there, and give them out, charge the patient for the medication. Okay, this luckily it caught on big time for a short period of time, and when physicians officers realized what a pain was, kind of gone away. We will still have some of this done in different communities. The main thing was that you got pharmacy in uproar. We were very concerned about it. For the legislature, got the Board of Pharmacy involved, and they said, okay, some people wanted to just say it was prohibited, saying that it got around the check and balance of a prescriber prescribing and a pharmacist reviewing and making sure everything was in that triad of patient, pharmacist, prescriber triad there as far as making sure everything was balanced. They were not going to be successful in pushing it away with just that argument. So they said, okay, we're at least going to regulate it. And the main thing they did was just say, fine, if you want to be a pharmacy, you got to do everything pharmacy. And this is where they started finding out that it wasn't all that much fun. And they might make a little extra money, but it wasn't going to make up for it. So all the record keeping they had to do, storage, inventory, they could be
I just feel so awkward. I know my heart's
inspected. They had to notify the Board of Pharmacy that they were going to do this. DDNA would show up and inspect them and make sure that their drugs were being stored appropriately. One of the biggest things was that they were labeling them
Oh my god, I feel
correctly.
awkward.
I know.
With appropriate directions, patient information, number to call for the pharmacy or the dispensary, things like that. They were just, had a bottle of 30 blood pressure medicine with the name of the blood pressure medicine. They put the patient name on it and say, take one of these every day. That wasn't going to fly. They don't let us do it that way. They don't let the practitioners do it that way either. Again, there is an exception in that. Remember, anytime there's a rule, there's usually a few exceptions. That's an area you need to be focused on for exams, but also in practice.
Oh my God, I said
Veterinary medicine has been doing their own dispensing for years. Right?
I'm sure mine just.
Probably some of you now have some veterinary medications, or you have pets that your patients have, and they're vet prescribed drugs that are human use drugs. They get them from your pharmacy. But there are still specific veterinary use medications, and most frequently, it's still easier for us or anybody to take their pet to the veterinarian, for the veterinarian just to dispense that drug. Since they have been doing it forever, they were exempted from these new regulations. Okay, so they might give you just a package with your pet's name on it. It has some instruction print on it that use it, as directed. Like that. So they're an exemption from the practitioner dispensing these drugs. They must notify the medical board. They must notify the board of pharmacy, practitioners, non-veterinary practitioners that want to dispense their own medications to their patients. And they can only dispense to their own patients. They want to start dispensing to everybody in the doctor's building there. They have their own retail pharmacy. They are limited to only dispensing to their own patients. Believe it or not, there is something like a technician called a practitioner's assistant. So we know that the prescriber is not the one going back there and labeling these things up and making sure the right thing is being given to the patient. They've got their person that does that. Well, that person is called a practitioner's assistant, and notice that they can only have one. None of this 2-to-1 or 3-to-1 or anything like that. It's a 1-to-1. And the prescriber must be present and personally supervising. In other words, the patient can't just drop by there on the day the office is closed and have that practitioner's assistant or the person answering the telephone or the nurse or something like that give them their medication. So again, they pretty quickly realize, oh yeah, there's refills. People need their drugs on Saturdays and Sundays and evenings, things like that. So again, this is not as big a deal now as it once was. Hopefully it's not going to come back on us, but there are some very specific requirements on that. They do label the, as most of us know, most physicians now practice in a group practice. Not all of them can do their own dispensing, or they would have to have 5 or 6 dispensaries. So in order to have just one per office, they have to have a practitioner who is named the practitioner in charge. And again, that's the person, just like with the PIC, if GDNA has a problem, or there's an issue, or they want to go in and inspect, they're going to ask to speak to that person. If they were on duty that day, they're going to want to talk to the practitioner in charge.
Yeah, I would say something. I should call her.
Again, just to kind of complete the whole package here, they have to do the same things that pharmacies have to do. If there's theft or loss, they have to report it to local law enforcement, EPA, and GDNA. They have to fill out the form DPA 106, just like the pharmacy would have to do. The board may inspect their records. They don't necessarily go by and inspect them every 2 years, but again, I'm sure that initially they're going to be watching them. So, because again, they don't really realize what they're getting into most of the time when they start doing it. Controlled substance, of course, is a bigger deal. Most of these practitioners that dispense, you will find that they do not dispense controlled substance. Because again, there's much more record keeping and risk on their part as far as having those in the facility. Okay, the last thing we're going to cover are a few other types of permit types in Georgia. Again, most of you know I'm a nuclear pharmacist, so I can't go without talking about that a little bit. I'm not going to hit that very hard. Also, some things you may not realize are there, but as you know, we have a lab, pharmacy lab there in the Pharmacy South, where you practice counseling, you practice dispensing, you practice, product selection, all those kind of things. So we have dangerous drugs and controlled substances on site. So there's actually a type of permit for colleges of the pharmacy to have, just to have those drugs back there used in lab for teaching purposes. I mentioned the outpatient clinic pharmacy, or OCP. We're going to talk about those. And again, this is different than just, most hospitals have an inpatient, and then they have some kind of other pharmacy. We have one downstairs here at Candler, where they dispense sometimes to the general public, sometimes just to their employees or something like that. And they'll refer to that as the outpatient pharmacy. Okay? want to differentiate this from that, and it's always referred to as outpatient clinic pharmacy. And again, you might have a clinic that dispenses on an outpatient basis, but you'll see when we cover this that it's very specific as far as the type of patient and the type of dispensing that can go on in what is actually defined by Georgia regulations, outpatient clinic pharmacy. And then the last thing we're going to cover are RAMs, which we mentioned earlier on. We talked about the robotic pharmacy system. We said we're going to hit RAMs. RAMs are remote automated medication system. Basically, it's very similar to what you might have in an inpatient or hospital pharmacy, the Pyxis cells, things like that, except rather than being physically located within the facility, license of the pharmacy, these are separate. And most of the time, these are going to be in long-term care facilities. Again, we talked about that early on today. Still got that consultant pharmacist that has to come by and review those charts, and instead of having a vendor pharmacy bring carts or bags or boxes of drugs out, they actually have these remote medication systems that already have the drugs stocked in them. And very similar to the way a system works in the health system, where the pharmacy can program it to deliver certain medications for a certain patient at a certain time. These are done, but it's remote. It's not in the same facility. It could be miles and miles away. Okay, nuclear pharmacy, something that's kind of unique to that is we're controlled, or we're regulated not only by the Board of Pharmacy, we do have specific regulations for them, but we're also regulated and inspected by the Department of Radiologic Health. The Department of Radiologic Health is just basically the state's equivalent to the NRC, Nuclear Regulatory Commission. They're the same ones that regulate and they inspect, the same inspectors that go to nuclear power plants. They go out here to Kings Bay where they have nuclear weapons, and they go into your nuclear pharmacy. And a lot of times they have no idea what you're doing, but they are responsible for regulating. That's about all I'm going to say about nuclear pharmacy. I can talk with any of you much more about that if you're interested down the road. Pharmacy school pharmacies, it is required that you have a license before you have those drugs placed in that lab. You have to have a PIC. You can imagine, Dr. Seagrave is our PIC for our pharmacy school pharmacy. The big difference in that type of pharmacy, you must have everything stored appropriately. We are able to have out-of-date drugs, so we don't have to buy new drugs all the time, but the main difference is that we may not dispense. Okay? So this is totally separate from, for example, over at Health Services. They have a retail pharmacy license over there to dispense the medications they dispense. Pharmacy school is not allowed to dispense. Okay, outpatient clinic pharmacy. Frequently, these things are also referred to as surgery centers, could be urgent care centers, infusion centers. We've got one right upstairs here in the Candler building where patients come in and have medications infused for chemo, various types of antibiotics, things like that, or an ambulatory care center. But specifically, an outpatient clinic pharmacy only dispenses drugs that are used while the patient is physically present in that clinic pharmacy or in that clinic. Okay? So again, make sure you differentiate this. I call this outpatient clinic pharmacy, capital letters, and it does have a specific license type, versus just a pharmacy that dispenses the outpatient. Okay? Most of those are retail pharmacies that dispense to patients, give them their drugs, they're going to take home and use it for the next month or whatever. An outpatient clinic pharmacy specifically, that license is only to provide medications while the patient is under the care of that clinic. Okay, again, probably the surgery center is the most frequent one of those. Infusion centers, a lot of money in infusion centers, so those are increasing. But again, the medications they use in that infusion center are the only thing they can dispense with. The medications are actually used while that patient is in the infusion center or while they're under the care of that surgery center. They can't give them some medication. If you have a little day surgery, you've been here for 23 hours, we're going to send you home now, and here's some pain medications for the next 2 or 3 days. You can't do that. An outpatient clinic pharmacy license. If you're going to do that, they're going to have a retail pharmacy license. If they're sending any drugs out to the patient, it's going to be used after they're outside of the care of the center. Okay, that's a specific difference there. They can give them a prescription, but they can't fill the prescription. Okay? Again, because these drugs are all used on inpatient, there's no consideration for refills. Again, if they're prescribing for something to be taken later, they have to give a prescription to the patient, and it can be filled in a retail pharmacy. They want to get into the business where they're filling those prescriptions, they would then have to have an outpatient clinic pharmacy license and a retail pharmacy license. Okay? Most of them don't want to get into that. Again, pretty standard. They have a pharmacist in charge. They have policies for the use of those drugs in the absence of a pharmacist. Works out real well in this one because they're right upstairs here. We're physically connected to the pharmacy. There's not always a pharmacist up there, but there's always a pharmacist over the inpatient pharmacy, and they frequently come over to answer questions or give in service on the drugs that are being used in the clinic pharmacy. Okay, there's another section called controlled substances. Comes up now. This is very different than all the controlled substances we talked about before. Right now, there are no active drugs that are specifically defined as controlled substances under this chapter, but there are old drugs that used to not be controlled substances on a federal basis. This basically is the paragraph whereby the Georgia State Board of Pharmacy can decide they're going to make a drug a controlled substance. They're going to take a dangerous drug and say, because of our concern about the use of this drug in these communities, we're going to classify that as a controlled substance. And it can be any level of controlled substance they want it to be, but the idea is that these drugs are not also regulated as controlled substances on a federal level. Believe it or not, Soma or Prodol was one of those drugs for many, many years before it was actually classified as a controlled substance federally. It was on the records in many states, not just Georgia. Ketamine, sodium oxybate, kind of the new sections. These are C1 drugs. These are the synthetic cannabinoids. It's the one they keep coming out with slight variations of them. This is so that the Board of Pharmacy can specify these as controlled substances, even if they haven't been specifically named that by the federal government, the DEA. The latest one, which again is old news now, was hydrocodone combination products. They actually made, they were already controlled substances, but the state of Georgia made them C2 drugs about 2 or 3 months before they were designated that at a federal level. So again, there's no specific drugs now that aren't already classified as controlled substances at the DEA level, but as you go through practice, there will be some, and if you say, gosh, what's up with that? How it's not a controlled substance federally, it will show up under this section of the Board of Pharmacy regulations, where the Board of Pharmacy actually specifies the controlled status of those drugs, whether it's upping it from a 4 to a 2, or taking it from a dangerous drug to a 4 or a 3, or any of those kind of things. These are drugs that are specifically only controlled substances in the state of Georgia, or they were at one time. All of these are now controlled substances at the federal level. Okay, a very important area, particularly as you're getting ready to go on APPEs and thinking about career opportunities and talking about clinical pharmacy practice. This is an area, again, where Georgia, we frequently think that we're not maybe as progressive as some states. Georgia law is pretty progressive on what they refer to as drug therapy modification. This is what your faculty members refer to as prescribing by protocol or pharmacist prescribing. All those kind of terms, those aren't really the terms. In Georgia, it's called DTM, or drug therapy modification. And frequently, because it requires certification, it's actually called CDTM. So if you see that, first of all, don't confuse it with MTM. We've learned about that too, medication therapy management. This is something different. This is where you're actually, by protocol, a physician or a prescriber can delegate authority to you to modify therapy. It doesn't mean just taking the same drug and changing the dose or the frequency. It can be, if you're certified to monitor hypertension, it can be changing the drug product, all those types of things. Okay, so it's very powerful, and it's really relatively easy in Georgia compared to some of the other things that, for example, even nurse practitioners or PAs have to do. It does have to be specific to the type of medication that you can monitor. They can't just say, I'm going to turn over the following of this patient to a pharmacist and they can modify all their therapy. It can't be that specific. I mean, it can't be that non-specific. It has to be specific to a certain type of drug therapy. A few requirements in order to apply for this. There's a fee, of course, like with everything else. But you also have to have at least 3 hours of CE specifically related to the drug therapy modification that you're wanting to be allowed to do. Now, most of these people, they've done residencies, they've done years of training in these things, so that's not that big of a deal. But CE is something the Board of Pharmacy can understand. So they said, well, we need to make sure this person has background in this area before we certify them to make those kind of decisions. So they do require you to have 3 hours at CE, which is really not hard to do. And then they do require, the only time live CE is required in the state of Georgia, you must have at least 1 hour for renewal. And the renewal is annual, not 2 years. So you have to have at least 1 live hour of CE in that specific area every year. So it might sound like it's a little specific, but it's really not hard to do. Physician may delegate authority to the pharmacist. It must be in writing. It has to be a written protocol. You have to, of course, have on there that has to be signed with a license number of the pharmacist is issuing that to you, and information as far as your licensure. That individual protocol is good for a maximum of 2 years. I notice you have to renew that license every 1 year. But you can use the same protocol for 2 years in a row. After 2 years, you have to have that protocol rewritten. They have to talk about the type of diagnosis the patient would have and the type and category of medications utilized. So it has to be pretty specific. It can't be as general as a nurse practitioner or PA. Again, frequently it's in diabetes management, hypertension, lipid therapy, things like that. A lot of your AmCare pharmacists, and we have a lot of them here with the CMM, Center for Medication Management, that have multiple protocols that they are authorized to modify therapy on. So they practice and then write prescriptions and do all these things very much like a nurse practitioner or PA by delegated authority from their supervising prescriber. Okay, don't forget about that in Georgia. I think the chance for this to grow, particularly into other more traditional community pharmacy practices, is very good. As we train more with these prescribers, you go through things like these IPEs, and they get to know what you can do for them and what they can do for you. You'll be on APPEs with these people. They will start, after they ask you a question or two and you give them some good information, they're going to start relying on you for that information. Realize these are the kind of things that can build into a practice where you would have these types of protocols and be able to manage your patients. And again, you are much more accessible in those cases than these other types of prescribers. So that's an area where Georgia is pretty far ahead. In addition to prescription records that are required for dispensing, this one does require medical records, very much like the home health care registration that we talked about. It is required that you keep a patient medical record, documentation of things that we don't always have in a traditional pharmacy, lab results, things like that. And this is one of the few times in Georgia regulations where it says the record should be maintained for 10 years. Remember, we talked a lot about that, and again, kind of in summary for the whole semester. Most of the times we've seen it in Georgia records, it's been 2 years. We saw a few things for 3 years. We saw medical records in hospitals for 5 years. But the longest thing that overshadows almost everything we do is if anywhere along the way, any of the prescription payment is provided to a government agency, which is many, many of them, all the Part Ds, Medicare, Medicaid, CMS requires us to retain those records for 10 years. So 10 years is kind of the standard out there as far as, you keep things for 10 years, you're pretty safe as far as having that. Again, with the document storage mechanisms we have today, and hard drives, and scanning, and things like that, there's no reason to not keep these things in perpetuity. But as far as paper records, again, that's the original. I probably want to keep that for 10 years, just to cover everything, including CMS. There is some specific language in there just to make sure people don't confuse DTM with the ability to substitute generically. There is nothing in there that should prevent you as a pharmacist doing your usual job of substituting generically, as long as you follow those other requirements. And also there's specific exceptions for hospitals, because hospitals practice by protocol and have for a number of years. This is just expanding that ability, and a lot of y'all will see that being done on your APPEs, which start those in just a few weeks. They don't have to have DTM certification to do that in the hospital. It's done within the hospital's structure through the medical board, and the P&T committee. Okay, last but not least, the RAMS. One more abbreviation, Remote Automated Medication System. Very similar to the robotic systems we talked about before, either used in a community pharmacy practice or most like the ones that are in health systems. The key thing here is that it is not on site. It's physically separated, some kind of electronic communication that goes back and forth to allow those medications to be dispensed remotely. Most of the time, you're going to see these in long-term care facilities. That's the most frequent use of them now. That was basically the group that went before the Board of Pharmacy to get these things approved. This is jumping back into the old section of notes from Part 2, where we talked about the robotic systems, automated pharmacy systems. So don't get these confused. They're very similar as far as mechanisms or even the equipment itself. But the very big difference here is that these remote systems are not physically located in the same facility that is licensed to use the robotic system. The way the Board of Pharmacy chose to handle these is basically require each of them to be licensed as a separate pharmacy. Okay, it's just a piece of equipment with all this interconnectivity to the home base, the long-term care facility vendor pharmacy. But each of these has to be specifically licensed because it is a standalone place where dangerous drugs and controlled substances are made available for dispensing. So just think of them each as a little mini pharmacy. They have to have their own license. They have to be, the area has to be inspected by the GDNA, and it can be inspected at long-term care facility. They have one of these in there. GDNA can inspect that at any time. Restocking. Remember we talked about these as pharmacists or an intern technician under direct supervision, on-site supervision. For these remote ones, a pharmacist or an intern under direct supervision. Not just an intern sent off in their car with a box full of drugs, but essentially it means that a pharmacist has to be involved in restocking these devices. This was a big point of contention when these regulations were going through. The long-term care facilities and realistically some of the vendor pharmacies were thinking, hey, we would really like the nurse to be able to restock it.
And you have to pay for it.
Realize the argument was made, first of all, that might take some pharmacy positions out of the beds. But the biggest concern was the type of error that could be made if someone made a mistake and they're restocking these devices. If you put the wrong medication, the wrong bin, the wrong receptacle in one of these remote systems, it doesn't mean that just one patient gets the wrong medication. It means that every patient is going to have anything dispensed out of that particular type of drug can get the wrong medication, wrong strain, wrong drug. So that was sufficient to get the Board of Pharmacy to agree and say that we're going to go against the wishes of some pharmacists and also these long-term care facility management people, and we're going to say no, a pharmacist has to be involved. Every 30 days, they have to do an inventory of all drugs, make sure that everything's balancing. Everybody's found a way to get medications out of the system that should not be dispensed. For controlled substances, they have to do a 7-day inventory, and they did concede that that could be either done by a pharmacist sent out to do that or the nurse. Again, that wasn't as big of a concern because, again, the nurses are doing the controlled substance inventory up on health, on patient care areas and health systems anyway. So the controlled substance inventory on a 7-day basis can be done by a pharmacist or a nurse, but all of them have to be inventoried by a pharmacist at least every 30 days. Maintain control. Okay, and folks, that's it. That's all of Georgia law. You've got from now until next week to study. Get ready for the exam. Remember, we've got there were questions in the back of the textbook. Those of you who bought the book or those somebody that has the book. There were review questions. I didn't necessarily go through those to make up the final exam, but it just kind of gives you an idea as far as preparing for this exam, but also thinking ahead. It's going to be this time next year. You're going to be thinking about preparing for the MPJE. I will follow up with you next year. I'm going to be meeting with the P4s the week after they finish their rotation. And I always talk about other resources you have. One of the biggest things you have going for you is your Access Pharmacy. You have access to that through your P4 year and actually a little while after you graduate. You have to ask them specifically how long when they drop you from that. There's some very good review books. One of the best ones is the Feinberg Guide. And the reason it's the best one, not that you need it for Georgia, but the Feinberg Guide that's in the Access Pharmacy actually has appendices for about 26 or 28 different states now. So those of you that are going to another state and have to take MPJ in that state in order to get licensed for your residency, that's a real good resource because it's going to have a snapshot of what's different about that state.
We'll probably just chill here.
Yeah, I'll probably.
For Georgia, there is no better resource than the website. And I hope that you've looked at that maybe a time or two through the semester. It's not easy reading, but hopefully now you have a little different basis as far as being able to look at it as that outline that you used in class. Go in there and look specifically for different topics. Just happen to have that pulled up here. Show you one last time. As I mentioned on there, there used to be something called the administrative history. It was very accessible. You can still access it. We'll show you how to do that. Got logged out here. But what I'm hoping you will feel like now.
Yeah, I think when.
Well, I always try to open it for class. There we go. Okay.
Well, I think
Under Board of Pharmacy website, rules and regs, this is the outline. This is what we've been covering, and we've gone through. Here's covered today: practitioner dispensing of drugs, patient counsel we've talked about, outpatient clinic pharmacies. There you go. Remote automated medication. Like I say, there's several other things, but this has to do with just general operations of Board of Pharmacy. Basically, these are the various chapters. It may not word it just like we talked about in class, but you can read through the legalese, or you'll still have my notes to look back on. One thing, if you're working in a particular area, I usually use pharmaceutical compounding as an example.
Oh my God.
If you haven't worked in compounding for a while and you find out that you're going to actually be taking over a compounding pharmacy or whatever, one thing that's useful to see if there's any recent updates. Within each of these sections on the Board of Pharmacy website, this is actually the administrative history. It talks about the history if it had a previous name before and the date that it became effective. Here's the interesting stuff with the amendments. It will show you when that regulation was last updated. In this case, this was updated in 2014. That had to do with that change in wording that we talked about, where they took out the ability for you to compound things that are not on the market federally.
That's not shut.
So that was changed in 2014. Again, if you're looking to see if there have been recent changes to any of these things, you can go to the end of that section and look on there and it will give you those dates. That could be helpful again if you have been out of a certain practice for a while and you're going to maybe go into the hospital, or if you're going to become a director of pharmacy, you can go in there and see what things have changed. It also, another convenient thing that it has, it actually lists references. Remember, the OCGA is actually the law, legislative laws in the state of Georgia. It also references which actual laws those regulations are based on. Okay, so you're going to have to take it back to the law section, way of doing that. Okay. Again, that's the end of the course. I've enjoyed it. I enjoy teaching the course. I learn something every time I do it.